This is National Institute of Health Research, listed 5 amazing breast cancer, amazing health research breakthroughs, and they included intraoperative radiotherapy as amongst these breakthroughs. And other breakthroughs which were included were the COVID vaccine and COVID treatments, completely unbeknown to us. So it was quite nice to have this accolade. So why is it a breakthrough? Because breast cancer affects a lot of women. Just in 2018, 2 million people were diagnosed around the world, and 626 women died of the disease. And over 10 years, this amounts to 6.3 million women. So let me start. You have breast cancer. And this was back in 1991. And I was working at the time in Tata Memorial Hospital. So at this point, what is the patient thinking? She is thinking, can I come to the hospital every day for 6 weeks? If she could say yes, then we could preserve her breast. And if she said no, we need to do a mastectomy. Now, this is a problem. And this has made many patients choose a mastectomy instead. And should they have to do it? This is what led us to the idea of giving localized radiotherapy. This problem is not limited to India. It is there in Australia, in Denmark, in US, where people don't want to cross the Bay Bridge, and in UK. You can see these red circles. Each of them is a 13-mile radius. And people in the green area have to travel more than 13 miles, sometimes 2 hours a day, every day for 3 to 6 weeks for the radiotherapy. So it is a problem that affects us still. So this concern about patients, luckily, serendipitously coincided with the lab work in which whole organ analysis of mastectomy specimens was performed. And in this, what was found is that breast has many microscopic cancers. Yet, most recurrences, which are shown by red dots here, occur around the primary tumor. So we felt it is probably sensible to give radiotherapy only around the primary tumor. And this is what we published in 1996 and 1997, along with Professor Michael Baum and Professor Tobias. So this academic insight suggested that we should radiate only near the primary tumor. And the new idea was to give it during the lumpectomy procedure itself. And for this, concept of TARGET evolved. And TARGET is a short form for targeted intraoperative radiotherapy. So the device was created with industry collaboration, surgical technique was invented, and a randomized trial was performed. So this happened on 2nd of July. This is the photograph of the first case. This is the tumor bed where the applicator goes in. That's how it looks in the operation theater. And here it is with me with Professor Michael Baum when I was much thinner. And this is with Professor Tobias in the operation theater performing the operation. So what we did was we challenged the dogma of radical radiotherapy in the last 25 years. As we moved from radical surgery to more targeted surgery, in the last 25 years, we moved from radical radiotherapy to targeted radiotherapy. So this is the target technique. Radiotherapy is delivered immediately after lumpectomy. Focused radiation is given to the tumor bed itself. It targets tissues at the highest risk of local recurrence and avoids normal tissues such as the heart and the lung, based on the principle of precision and immediacy. In addition, it is individualized. So you choose the correct applicator for the correct tumor according to size of the patient's tumor bed. So this is how it looks in the operation theater. So this is the normal COVID gear that we have to use. It's COVID safe. And this is how it looks from the side. This is the machine. And this is how it looks on the patient. So this covers the shield in order to protect the theater staff during the radiation. It is ideal during pandemic because it's done and dusted in the same time as your lumpectomy. So we published the technique and the first 25 patients and proved that it worked and it was safe to do so. So how do we test the effectiveness of target IORT? The gold standard for this is a randomized clinical trial. And in this, we asked, can risk-adapted intraoperative radiotherapy replace standard postoperative radiotherapy or not? The recruitment occurred between March 2000 to July 2012. 2,298 patients participated in this. They had to be 45 years and older, and the tumor size should be less than 3.5 centimeters in size. During this time, the obvious benefits of target IORT were confirmed in the following studies. So these are the obvious benefits. Cosmetic outcome with intraoperative radiotherapy is superior to standard whole breast radiotherapy. Quality of life is superior with target IORT. Patients have less pain, less breast and arm symptoms with target IORT. Patients and doctors both prefer target IORT given a choice. So this is an important point. Patient preference is so important. Then we checked the cost. We found target is cost saving. So in US, $1.4 billion would be saved over 5 years if target was used for suitable patients. The cost saving in the UK is less because it is cheaper to give radiotherapy, but it still would save about £9 million per year. And this is interesting, that target reduces patients' travels. This is obvious, but we actually measured this. So this is a small video recorded by Mr. Nathan Coombs, and he's taken this video as if his patient is doing the travel.
I realised that while I'd be driving this only once or twice a month, most of my patients would be asked to drive this at least 3 or 4 weeks for their radiotherapy. What a horrible journey I thought they had to put up with.
So this is the journey in UK. Imagine how it is in other parts of the world. And if we can save this journey, I say with a tongue in cheek, that target actually could reduce global warming. There is another interesting part, and this is the last part of this part of the presentation, that target improves tumor microenvironment. Now, this is a scary part for a surgeon. When we do surgery, the body tries to heal. And body trying to heal means it is stimulatory. What we found is the wound fluid, when we put it on breast cancer cell lines, it stimulates motility, invasiveness, and proliferation. But the good part was that if you take wound fluid in patients who have had intraoperative radiotherapy, this stimulatory effect of wound fluid is abrogated. And you can see here, the top one cells are moving much faster than the bottom ones, as seen in these diagrams, where it was objectively tested. So cells are less invasive, less motile, and less proliferative if they receive intraoperative radiotherapy. So this is a way in which it could work even more than what standard radiotherapy would work. Patients were randomized between year 2000 to July 2012, and these are the long-term outcomes. For long-term outcomes, it is very important that the follow-up is complete. Teams from all over the world helped in getting this high level of completeness. Surgical Interventional Trials Unit in UCL, each of them was blood, sweat, and toils. So Target A consequently has one of the largest amount of follow-up information about how patients have done for a long time in all comment to all similar trials. Another important point about the patients who participate in these trials, but there was a substantial proportion of patients with high risk of local recurrence. They were not the patients who were very low risk of local recurrence. There were a lot of patients who were young patients who had grade 3 cancers, many with positive nodes or ER negative cancers. So this meant that this trial population represented the typical patients representative of breast clinics. So we have seen the advantages of Target A. The important question that patient has in their mind is, what is my chance of living without the cancer coming back? So here are the long-term results. So they were published in the British Medical Journal after thorough peer review, and they were also published earlier this year in British Journal of Cancer, where we gave more detailed analysis. So the first question is, what is the chance of remaining free, cancer-free in the breast? And what is found is this local recurrence-free survival. There was no difference in the local control of breast cancer at all. And it did not matter what type of tumor it was, whether it was whatever the size, the grade, lymph node, ER, PR, or HER2 status. The local control was the same in all these subgroups. Now, local control is important because local relapse after whole breast radiotherapy does confer a poor prognosis to patients. But remember, that is for patients after whole breast radiotherapy or after no radiotherapy. So in the trial, we did find that long-term risk of death, breast cancer death, after whole breast radiotherapy is high. It goes up all the way. Okay, but what was good was long-term hazard of after local relapse of the rare times when it occurred after Target IORT was the same as if they had no local recurrence. So that showed us that the outlook, even after the rare local recurrence, after having a Target IORT, remains excellent. It's as good as having no local recurrence at all. So this was a good news. Then the next question patient will ask, what is the chance of my preserving the breast for the next so many years? And as you can see, these lines are overlapping. So there is no difference in breast preservation rate with Target IORT versus whole breast radiotherapy. Next question is, what is the chance of remaining free of disease, cancer coming elsewhere in the body? And again, there is no difference between the two arms of the trial here. Breast cancer mortality. we find breast cancer mortality is no different between the two groups. But this was the good news. The deaths from other causes, such as cardiovascular causes, lung problems, other cancers, were far fewer with target IORT compared to whole breast radiotherapy. And this is a big difference of nearly halving such deaths, 9.85% versus 5.41%. And this difference is not a surprise. Why is it not a surprise? Because harmful effects of scattered irradiation following breast radiotherapy are well known and documented for many years. It affects the heart and the coronary arteries. So you can see here, perfusion defects, that is damaging the blood supply to the heart, occurs within 6 months of normal radiotherapy. It can cause cancers of the lung, the esophagus, and sarcoma. This scattered irradiation is avoided with target IORT, so it is not a surprise. Now, this increase in heart attacks and lung cancers is significantly more if you have been a smoker. So there's a 6% increase in deaths due to whole breast radiotherapy. So I believe, really, the benefit of target IORT is so much more if you're a smoker. And I think for smokers, this is really the only safe option. If radiotherapy is causing this harm, is no radiotherapy a good idea? Well, this randomized trial, PRIME 2, shows that it is not. If you give no radiotherapy, even to the highly selected good prognosis patients, at the end of 10 years, 10% people get a local recurrence. And they don't even have the benefit of avoiding the radiotherapy, perhaps because this increased local recurrence leads to some breast cancer deaths. So it's not a good idea to give no radiotherapy. Do patients want no radiotherapy? This has been looked at. So when patients are offered no radiotherapy, 3/4 of the patients chose target IORT. Only a few chose whole breast radiotherapy, and even fewer chose no radiotherapy. So if your patients are being offered no radiotherapy, it is not really a good thing. So it's not a good idea. There is another way you can give radiotherapy, is give it in a shortened 5-day regimen. It's called fast forward. Actually, I'm not sure it's fast forward. It's a bit backward because it is giving radiation to the whole breast. Scattered irradiation still occurs to vital organs. And in the trial, more people reported hardened and firm breasts, up to 1/4. And it is such in duration, according to the doctors assessing it, also was much higher. And we don't have long-term data. So it's not a good idea. There are other methods of giving partial breast radiation, using such things like these wires put in the breast. Now, I think when patients are given a choice, they should be shown these diagrams, these photographs, to decide which one they want. It is additional procedure, and there is no reduction in deaths. You can give it from using existing machines from outside, but again, there is still scattered irradiation and no benefit of reducing deaths, and still needs many visits to the hospital. Whereas with target, you have excellent breast cancer control and fewer deaths from other causes. Now, there's one more important outcome, that if you have patients which are grade 1 or grade 2, that is the better prognosis patients, which formed a majority of patients in the trial, 1,800 patients, there was an overall survival benefit of nearly 4%. Now, one may think, is this 4%? To contextualize it, this number is very similar to the improvement that patients get for ER-positive patients, less than 2 centimeters, if they're given Herceptin. You may have heard of Herceptin. It's an expensive drug, and it's given over a course of 1 year. It costs about 15,000 pounds in the UK, but $50,000 in the US. It can hurt the heart, but as target is actually cost-saving and protects the heart. So the benefit to the patient is very similar. So what are the new insights of the Target A trial that have been seen in this new publication in the British Journal of Cancer? Number one, who can have target IORT? And based on these data, we can recommend an evidence-based guideline that target IORT is suitable for all patients with any tumor subtype, as long as they would have been eligible for the Target A trial. That is, anybody who is 45 years and older with invasive ductal carcinoma as a single lesion, and which is up to 3.5 centimeters in size, irrespective of any other tumor subtype. Number two, who should receive external beam radiotherapy? And in this paper, we provide an interactive web-based decision aid, a tool for clinicians to help them decide who should get external beam radiotherapy based on any individual patient tumor characteristics. Number three, We found that when patients get a local recurrence after target IORT, their outcome remains excellent, unlike that in patients who have local recurrence after whole breast radiotherapy. And this is an excellent news for patients and for clinicians. And finally, what is the reason for this difference in non-breast cancer mortality? It looks like there are two reasons for it. One is the avoidance of scattered irradiation to the nearby vital organs at risk. And second is a possible, what appears to be an abscopal effect of giving target IORT during surgery, which has a beneficial protective effect against deaths from cardiovascular causes, lung problems, and other cancers. This last effect, the Target B trial, is going to actually test this, giving intraoperative target IORT boost versus postoperative external beam boost in young patients and those at very high risk of local recurrence. And it is already randomized more than nearly 1,400 patients in 38 countries. And in this trial, if we find a difference in non-breast cancer mortality, that will be the test of this hypothesis. So our original results of 2010 were now confirmed. What we have found is that target IORT is now widely applicable whenever a patient is planned to have a lumpectomy, but they should be told about it, informed about it before the operation, because it is done during the operation. Breast cancer control is comparable to the traditional long course. There are substantially fewer non-breast cancer deaths. There's substantially improved overall survival if grade 1 or 2, and excellent prognosis even after the rare local relapse. Of course, there are other benefits of less pain, better cosmetic outcome, better quality of life. It's more convenient for the patient, less travel time, and of course, less global warming. And there is lower cost to the patient, out-of-pocket costs, as well as to the healthcare system. So these are the benefits. And of course, this made a lot of news. It was on top of the front page of the Times. And people have asked, what is the downside then? Well, it challenges the dogma, and that leads to inertia. And this is a statement by the chief editor of the top radiotherapy journal, that depending on perspective, it could either be a quantum leap forward or a serious threat. But despite this, it has been considered as an innovative treatment, better than other PBI approaches, and it should be practice changing. And people around the world are using this. So these are real world studies from China, where they have found it's effective, USA, Russia, France, Europe. These are long-term data. And these are photographs of clinicians and teams, hospital teams, who have been using this as standard of care. And we have been meeting together since many years. And these are photographs in various parts of the world. You can see here, this is in the US, this is in Germany, this is in Bangkok, this is in Las Vegas, this is in Mannheim and Florida. And this was the last one just before the pandemic, where we met together in New Orleans. So this is an important take home, is that target IORT is now adopted all over the world. Each dot here represents a center which has treated patients. And I've contacted all of them, and they have told me the number of patients they have treated. And that number comes to about 45,000 patients in 260 centers from 38 countries worldwide. So this is really good that this is being used and offered to patients. In the US, they advertise it as one of the things that they offer. In the UK, we are good at innovation, but usually slow at adopting. But in 2014, NICE made a recommendation, a draft recommendation. And in January 2018, it recommended it should be used in centers that have the equipment and the expertise. And in this year, as I said before, National Institute of Health Research included Target as one of the 5 amazing healthcare breakthroughs in the last 12 months, along with COVID, treatments and vaccine. And if you follow the GMC guidance, NICE guidance, and the law, in which everybody should be given options that are considered reasonable, target IORT should be made available to patients whenever it is suitable for them. So the last part will be a small video from a patient.
I'm Marcel Bernstein. 8 years ago, I was diagnosed with early stage breast cancer. I had it for 2 months only before I was cured. I had TARGIT IORT at the same time as the operation to remove the cancer. I spent one night in hospital and I was back at work within days. No pain at any time, no complications, no scarring. I can't even tell where on my breast the surgery was. And no recurrence. 8 years. And that isn't just me being lucky. Studies show that my experience is similar to that of other women who've had TARGIT. I am so happy I was able to have this treatment.
I hope that this treatment is available to every woman to whom it is suitable. Every institute who treats breast cancer should have this technology available to them. And that is my hope. Acknowledgements are due to every patient who participated in the trial and all the staff and investigators who gave all their efforts to make this trial possible.